Is it working? Good afternoon, ladies and gentlemen. We have a couple of minutes, but I can start with the introduction. For the speakers, as a reminder that the schedule is very tight. I will strictly adhere to the time limits. Each speaker will get a reminder by looking at the flashing light a couple of minutes before, and we should not go over. This is very strict. Secondly, everyone who wants a question after the presentation would please go to the microphone. It's on one side. And if there are more than one question, you have to line up. And so I think I will start with my presentation as soon as the slides are there. Yeah. So this afternoon we are dealing with an important topic, that is various options for targeting. The active targeting by molecular recognition has refined applications, but not only for diagnostics, but for therapeutics as well as even prior to that for drug delivery. And important applications are in two areas: nervous system and cancer, although there are all the other areas are benefiting from these technologies. And an important relation to this in this conference is that many of these refinements are based on nanobiotechnology, and also there is a link to the development of personalized medicine. The objectives of the targeted approach is that you have a selected therapy to target an organ or a diseased target, and not to expose the normal tissues. And also for optimizing pharmacokinetics, just both degradation and excretion, and to ensure survival of the therapeutic molecules for the desired duration of action. Here is an example of pegylation for stabilization of the nanoparticles and avoiding recognition as a foreign body. And important thing is it enables us to reduce drug dose and toxicity. An important example is chemotherapy for cancer, particularly brain tumors. Instead of flooding the whole body with a chemotherapeutic agent, we can select if a target to the tumor itself. Enables us to give higher doses and avoid toxicity. For example, doxorubicin were limited by cardiotoxicity, and so we cannot really go very far in killing tumor cells, the brain tumor. And also to targeting means the control passage through barriers in the body. One example is again a blood-brain barrier. We just don't want that, let's say we have a nanoformulation of a drug. We think it will easily go through, so that problem is not solved like that. We don't want to flood the brain or expose with too much of the drug that just should be targeted to the lesion, for example, the brain tumor. And also this targeting enables us to combine diagnostic with therapeutics, which is an important feature of personalized medicine. And we have many options available that will be, most of them will be discussed in the following sessions. We can do this by use of monoclonal antibodies, are probably commonly used methods, both for diagnostic and therapeutics, and aptamers, oligonucleotide aptamers. The classical ones are many new modifications, as Spiegelmeier. And then there are nanobodies for the refinement for diagnostic and therapeutics, Saligo, synthetic aptamers, and we, of course, have several nanoparticles. We are not spending too much time on the classical nanoparticles, a big subject in itself. And we also have kinotins. I don't think we'll be talking about them. Cell targeting, as an example, can give you the multivalence attachment to target cells. And these multivalent attachments increase the specificity binding much more than monovalent agents, because several times of magnitude more than that. And the screening of a library of these nanoparticles decorated with the different synthetic small molecules against different cell lines enable us to match them. They are going to be targeting to endothelial cells, etc., or human macrophages. And this multivalent approach could facilitate the development of functional nanomaterials and applications such as targeting specific cell types. And the potential applications are, again, vary from high throughput drug discovery, diagnostic, and chemotherapeutic. I'll just, in the limited time, I'll give you just one example of this targeting therapeutics. And let's say this is a old model that I've been using to testing different compounds for targeted delivery to the brain. And one of the problems here is not just the introduction of the agent into the systemic circulation, but to cross the blood-brain barrier. And this concept involves a complex of a nanoparticle, therapeutic nanoparticle, a monoclonal antibody, and that would be binding to a receptor in the blood-brain barrier. So it's a receptor-mediated transport through the blood-brain barriers, more like a Trojan horse approach, where the barrier does not consider it to be a foreign substance, and so it goes through. So it's a controlled passage. And after you get into the brain, then you have to have a second stage where you're targeting the receptors on the surface of the cancer cell. Now, this is where there's still a problem. Say in earlier days, some years ago, we were targeting AFG, endothelial growth factor receptor, and that was quite common on brain tumors, but now it's found in many other tumors and other parts of the body, so it's not so specific. The problem and the challenge is not so much the technique to get to the brain. Once a particle gets there, it will penetrate the cancer cell. But the problem is to make sure that it's not getting into other places with the same receptors. And so for that, one of the next plan would be to choose a combination of two receptors that will be unique to a particular tumor, such as lesions such as glioblastoma. Although there are many receptors have been claimed to be unique, but as one investigates further, you find these in other organs as well. So I think these are examples of approaches, and I'm just giving it as an introduction, so I will stop here. And if there are any questions, a couple of minutes.